Did you get the slides, Hasnat, or should I could get the slide?
Okay, if you have gotten the slides, just run it because I'm just searching for it. Yeah.
1 second, 1 second.
We are live now.
Okay, this is the one.
Yeah, it is completely visible.
Okay, okay.
Okay. So, yeah, so a very good evening to all the participants and the speakers. So, I'm Dr. Khan Asnat from Pulse Pharmaceuticals. I am hosting this wonderful event and wonderful for this wonderful topic known as Apixaban in one of the many politic events. To just start with, I would just give a brief of thromboembolism and its incidence in India. So, thromboembolism incidence has rose up to 50% for the 2023 data as compared to the 2010. So, almost 50% increase in the incidences of thromboembolic diseases as compared to the past decade. This is due to many risk factors, like namely few, it is surgical, it is genetic, some environmental. Apart from this, some cancer, tumors, malignant, namely a few. From the past decade itself, for the thromboembolic diseases, there are a lot of therapies that have been used. Namely, a few therapies that have been used are warfarin and heparin that have been used, but it comes with a toss of a risk of gastrointestinal bleeding, a risk of intracranial bleeding. In the last decade itself, a new therapy have born known as novel anticoagulants. Now, what are these novel anticoagulants? Novel anticoagulants are basically that molecules that inhibits factor 10A in the blood clotting factor. Inhibiting 10A in the blood clotting factor comes with a lower risk of GI bleeding, comes with a lower risk of intracranial hemorrhage, and with a better safety profile overall as compared to your Asian therapies of warfarin or heparin in that case. Just to add on to this, today's topic is about Apixaban, which is again a novel anticoagulant drug, has been approved by FDA in 2015 for non-valvular atrial fibrillation as a thromboprophylaxis, as a treatment for stroke, and as a thromboprophylaxis for orthopedic surgeries like TKR and THR. So, with this wide indication, I would just to invite the two speakers here. And before invitation, I would like to describe a few words on them, and as well as on my company. So, I would just like a few slides on this. So, is my screen visible?
Yeah.
Yeah. So,
Yes, sir, visible.
yeah. So, I again cordially invite you to this cross-speciality discussion on the role of Apixaban in the prevention and treatment of thromboembolic diseases. Speaking about Dr. Balasubramanyam, he is an MBBS and MS in orthopedics, consultant orthopedic surgeon in Sagar Hospital and Banashankari and Shushil Orthopedic Center. He has worked as a consultant in Fortis Hospital, Nagar Bhavi. He has worked as a consultant in Manipal Speciality Hospital, Bangalore, and worked as a consultant in various hospitals like Sevashram Hospital, Swati Nursing Home. He has also been a part of the Sagar Apollo Hospital in Bangalore for the trauma cases and the spine and hip replacement there. Apart from that, he has also worked in the deemed institution of Sanjay Gandhi Institute of Trauma and Orthopedics in the for the trauma cases. Apart from that, he has a wide research in study of surgical management of displaced fracture neck of femur in elderly by bipolar hemiarthroplasty at Karnataka Institute of Medical Sciences, located in Hubli. We have a dissection which has been accepted by the same. So with this, I would like to invite Dr. Subramanyam into this wonderful event. Hello, Dr.
Thank you,
Subramanyam.
Asmat. Thank you, Asmat.
Moving on to our next speaker, Dr. Shridhar. So Dr. Shridhar is an MBBS, DNB, and a consulting physician. He is presently working as a full-time consultant at Unity Lifeline Hospital, Nagar Bhavi, and he has been part of this for the last 12 years. He has also worked as a consultant for the Fortis Hospital. He has worked as a junior consultant for 6 years in the nephrology department in Columbia Asia Referral Hospital in Bangalore. Then, apart from that, he has worked in various projects that taken up by the Department of Psychiatry for the projects of WHO. Worked on 3 papers which are presented at annual conferences of the Indian Psychiatric Society South Zone at Mysore, which was held in December 2002. With this, I would like to invite Dr. Shridhar to this wonderful event. Hello, Dr. Shridhar.
Hi, Iqbal. Thank you. Thank you for the nice introduction.
Yeah. Moving on, just to give a brief introduction about my organization, Pulse Pharmaceuticals. So Pulse stands for Passion for Innovation and Compassion for People. We are patient-centric, innovation-driven, integrated pharmaceutical company with inclusive growth model. We have completed 26 years in India and across the global markets. We have world-class R&D and manufacturing infrastructure. We have very strong leadership and operational team across all the business functions, namely marketing, sales, and medical. Apart from this, we are leading the space in nanopharmaceuticals and drug delivery research. One of our own patented technology, Aquel nanotechnology, which is marketed as Dexcel in the market. Strong presence in medical nutrition through Pulse NutriScience. And we are also following ourselves into immunocell therapeutics by developing novel CAR technologies. Our business philosophy consists of create customer value, high quality differentiated products and services by advanced technologies and patented products. So advanced technology includes our Dexcel, very own patented technology of Aquel nanotechnology. Apart that, we are also coming up with Lyometrics technology, which would be a clear solution of paracetamol for pediatrics. Our very own infrastructure consists of a manufacturing facility that is located at Genome Valley, Hyderabad. Another manufacturing facility that is located at Roorkee. Our very own Pulse Advanced Research Center. Our very own Pulse NutriScience R&D and manufacturing facility, again located in Genome Valley, and R&D facility that is under construction. So with this, we have been awarded with several awards like Udyoga Bharati Award in 2006, Hall of Fame Award in 2010, National Award for Quality Excellence in 2011, and India Small Giant Indian SME Forum in association with NGTV in 2018. So with this, I would just like to present a small corporate video of Pulse Pharmaceuticals.
Pulse, a true reflection of the heart and its functioning. A heart that is compassionate about others and passionate about its work. A heart that is dynamic yet consistent. A heart that is predictable and reliable. A heart that goes the extra mile to deliver what is expected. Our business philosophy encompasses these very principles. At Pulse Pharma, we feel patients' problems, think, innovate, and do everything that it takes to deliver cost-effective solutions. We have a well-aligned leadership team and a highly motivated functional team to carry out our mission. We innovate and develop products with unique functional characteristics that help us serve our customers' needs better. We develop innovative business processes that help us improve our efficiency and customer experience. We have world-class infrastructure that includes an integrated R&D center and 3 manufacturing facilities that help us develop and manufacture high-quality differentiated products. Our research efforts are focused on developing nanotherapeutics, nutri-therapeutics, and cell therapeutics. Our operational presence is spread across India and 40 countries worldwide. We reach out to nearly 250,000 healthcare professionals in various specialties through our sales team of over 1,000 people and our partner sales force in various countries. At Pulse, we work with a real spirit of Pulse to bring about a positive difference in millions of lives. Because we are compassionate about people and passionate about our work.
So without taking any further time, I would like to invite Dr. Shridhar at this stage and make it its own. So Shridhar, I would like to welcome you and would like to take stage to your own. Yeah.
Thank you, Iqbal. I will share my slides. Okay, so I think you can see the slides, right?
Yeah, yes, sir. Completely visible. Yeah, sir. You can start, sir.
So welcome all the dignitaries and delegates here for this evening session. Today, very important topic, practical aspects of newer anticoagulants in the management of thromboembolism, venous thromboembolism. So that is a topic, and very important topic because the incidence is quite high. If you look at the incidence from various countries, Western population, this is actually mentioned incidence per lakh person years. So you can see UK numbers 74 in the venous thromboembolism, DVT 40 and pulmonary embolism 34. Asian countries, again, it is quite high. Indian studies are not much. But if you look at the numbers, again, quite high incidence of thromboembolisms. And actually, whatever number we have mentioned here is just the tip of iceberg. So approximately 80% of the various DVTs are clinically silent. So most of them due to improper diagnosis or most of them are not identified. So, and not only that it's not identified, once there is initial episode of DVT or pulmonary embolism, the risk of recurrence is about 10% within 1 year and 40% in the later years. So that is very important for us to understand the thromboembolism as a entity. We know the stroke and MI we study a lot, being the first and second common. The next, venous thromboembolism, the third most common, we don't usually discuss much. I don't know, for some reason, even as a physician, I would say, though this is just next to stroke and MI, we don't discuss much about the venous thromboembolism as much as the first two medical events. So this is as common as 1 to 2 cases every 1,000 persons. So this is the importance of understanding the venous thromboembolism. We see on a regular basis. The Richard Virchow, I know this is, everybody knows about this, the Virchow's triad, which is the most important predisposing factor to thrombosis. That is the damage to endothelial lining of the vessel wall, hypercoagulable state, and the blood stasis. So all these things contributes the Virchow's triad, which is predisposes to thrombosis. So what are the conditions which can lead to thrombosis? The arterial thrombosis, venous thrombosis, and those which has defect in the blood, protein, and the platelet. The arterial thrombosis common is, we know, atherosclerosis. As age progresses, as multiple comorbid conditions comes in, the arterial thrombosis progresses. Smoking, again, is a very common predisposing factor for arterial thrombosis. Diabetes, hypertension, we don't have to mention. It is the most common cause. Diabetes, we know we are leading all over the world now. We are almost touching the capital of the world in diabetes manner in the incidence. High LDL cholesterol, hypertriglyceridemia, oral contraceptives is again a very important cause of thrombosis. Use of estrogens, polycythemia is again either primary or secondary to smoking. This is not diagnosed well. So polycythemia is one of the very important, many are undiagnosed actually, I would say, hyperviscosity syndromes and leukostasis syndromes. In the venous thrombosis, the most important today, what we're discussing, orthopedic surgeries, arthroscopies. Say any general surgeries also can predispose to venous thrombosis. Any immobility, malignancy, we know, sepsis, nephrotic syndromes, very common. Obesity, again, obesity is again very common these days. Varicose veins, oral contraceptives again can cause both arterial and venous thrombosis, and even estrogens. Other things, though not less common, again, the main limiting factor here is the cost of the laboratory tests, and most of them don't get diagnosed. So the antiphospholipid syndrome, the protein C and S defects, the factor V Leiden deficiencies, and plasminogen deficiency. So all this multiple hyperhomocysteine again is very, very common, especially in South India due to various factors, probably because of genetical and also because of vitamin B12 deficiency, especially in the South Indians. So though there are so many causes for thrombosis, today's discussion, we are basically concentrating on these orthopedic surgeries. So we know the different types of surgeries in orthopedics, arthroscopy, osteotomy, spinectomy. I think Dr. Balasubramanyam, I'm sure he will discuss regarding this. So the most important being the knee replacement and the hip replacement, and the joint revisions and joint hip fractures repair. So all these surgeries can predispose to the thrombotic events. So in knee replacement, again, as I said, the thrombosis of the leg veins or pulmonary embolism is a very common event, other than infections, stroke, and even the nerve damage. Even in the hip replacement, blood clots is the main complication. So how commonly do we see the thrombosis, deep vein thrombosis in the arthroplasties? So if you look at this study, this is again from the meta-analysis. Total hip arthroplasty, if you look at the DVTs, it is as common as 50% approximately. So 50% of them have some amount of DVT with the hip replacements. And if you look at the pulmonary embolism, 0.9 to 28% as per the different studies. Whereas if you look at the knee replacements, as common as 41 to 85%. So you can say approximately 75% of the individuals have some amount of DVTs, and pulmonary embolism is about 1.5 to 10%. So joint replacement patients definitely pose a high risk for developing DVT. So how frequently and how early will it happen? Usually it can happen as early as 2 days prior after surgery, up to 10 days being the highest risk. And the risk can stay up to 3 months until the individual is mobilizes himself well. So the risk can stay. So what are the options we have at this point of time? We know we have antiplatelets, we have anticoagulants, we have thrombolysis. So we'll discuss each of this and we'll know how different each of them are. So antiplatelets, we know it acts on the platelets. It's aspirin and clopidogrel. It breaks the platelets. It's a it prevents, and it's antithrombotic. It prevents thrombus formation. Whereas anticoagulants prevent clot formation when blood is not flowing. So we have heparin, low molecular heparin, and the newer anticoagulants. And what is thrombolysis? Thrombolysis is those which actually breaks the blood clot, which is already formed, and ensures the blood supply back. So the tissue plasminogen activator, what we regularly use for, say, myocardial infarction and strokes, acute strokes. So this is the difference. So what is, if you come to the anticoagulant, today's discussion, what we're talking about. So these are the classification of anticoagulant. Heparin, we have unfractionated and the low molecular weight heparins. Vitamin K antagonists, the most common what we've been using, the comedins, that is warfarin, and the direct oral anticoagulants, the newer agents, what we know now. This is the non-vitamin K oral anticoagulants, also called as NOAC or DOAC, direct oral anticoagulants. These are either working at the factor 10A or at the factor 2. Factor 2 is also called thrombin. So factor 2 is direct thrombin inhibitors, which is dabigatran and argatroban. Argatroban, we know it is IV, dabigatran is an oral drug. Whereas those which act at factor 10A are the most common being, we use rivaroxaban, apixaban, and endoxaban. The endoxaban is not available, is not yet approved in India. So what we have here is apixaban and rivaroxaban. So when we are treating with anticoagulants, so we are actually trying to destroy the thrombus. So when you are doing this, so we are actually on the other side, there could be a risk of bleeding. So the bleeding can happen anywhere. It can happen in the urine. It can happen in the gut, causing black feces, melena. It can be simple symptoms like bruising. Especially if you see the elderly people, a simple the touch on the hand may cause bruise on the hand, and nosebleeds, bleeding gums, or they can cough out blood, and even sometimes they can have, the females can have heavy menstrual bleeding. So all this could be the side effects of the anticoagulants. So what are the challenges we face? I think all the medical fraternity face this problem. Current anticoagulants, as we used to use the more heparins and the low molecular heparins, have to be used either IV or subcutaneously, and they require monitoring and dose titration to provide effective anticoagulation without increasing the bleeding risk. So what is that we can do? We need a more effective and convenient alternative anticoagulants, which can be used at fixed doses without much of routine coagulation monitoring and improving the current clinical practice. So that is what we are looking at. So what is the ideal anticoagulant, which doesn't need burdensome laboratory monitoring, the less drug-to-drug interaction, no bleeding tendency. You can predict the pharmacokinetics, half-life, and the duration of action, has a specific antidote, and which costs reasonably less. So that is an ideal anticoagulant. Do we have any? So that is what we look at. These are the different anticoagulants we have. I will not go into the details of this. It's a very busy slide. We know all this. So before seeing what best we have as an ideal anticoagulant, we'll see what are the anticoagulants we have and how we are using it right now, and what is the management strategies for the venous thromboembolism. What we used to use till now, so the treatment is divided into 3 phases. The initial phase of about 5 to 7 days, the intermediate phase from 1 week to 3 months, and extended period beyond 6 months. So initially you start with, we used to start with heparins, either unfractionated heparin and the low molecular heparin. Then we used to overlap with warfarin for the last 2 days, and then we used to continue warfarin as much as required. And then we used to monitor the INR. Based on the required INR, we used to increase the dosage of the warfarin. So that is what we used to conventionally do until now. But with the recent introduction of the newer anticoagulants, oral anticoagulants, now with the dabigatran and edoxaban, we as an acute treatment, for the first 1 week, we can start with low molecular weight heparin subcutaneously and then followed by dabigatran. Here we do not have to overlap with dabigatran. We can actually start, so we can stop low molecular weight heparin and start with the dabigatran on the next day. So 150 milligrams twice a day. If it is an elderly patient, we can start at 110 milligrams. And even if the creatinine clearance is on the lower side, again, we consider only 110 milligrams. We will not start with 150. Instead of that, we'll start with 110 milligrams. So that is what we have been using it. And what next? So that is what we are looking today. That is the discussion. So can single drug approach be used? So instead of starting with the low molecular heparin and then adding on with a second agent, oral anticoagulant, can we have one single drug which will take care of both the initial treatment and the subsequent treatment? So that is what we are looking at. The single drug approach with Apixaban, it is definitely possible. The Apixaban, we can start with 10 milligrams twice a day for the first week, then reduce to 5 milligrams twice a day, and then subsequently after 6 months, we can reduce to 2.5 milligrams twice a day if necessary. So if the patient needs, the patient's condition requires the continuation of therapy, then you can continue with 2.5 milligrams twice a day for lifelong. So the Orexaban can also be used, you start with 15 milligrams twice a day, then 20 milligrams, and then 20 milligrams as a OD dose. So this is what we have been using. Edoxaban is not approved for treatment in India right now. So should we use the new agents right now, or we were quite happy with the warfarin therapy which we are using in the past? So what is the difference between the warfarins and the newer anticoagulants? So warfarin, we know it has a very high drug-to-drug interaction, high food interactions. It's a slow-acting drug. You need some time for the INR to reach the particular level. So you need to actually overlap with the heparins for some time, at least for 1 or 2 days, for at least 2 to 3 days, and then look at the INRs. So those who are treating I think all the medical fraternity treat the thrombosis at some point of time. So what we have seen is when we send the patients for testing for the PT-INR, every time we face this issue, we know certain labs are not very specific in testing these reports. The same lab, you send 2 blood samples, they give different reports for the same individual. So this is quite common, and it's very difficult to believe the reports what we are having. Say sometimes we go on increasing the dose of warfarin, but we reach the INR, desired INR level. But suddenly the patient comes after a few days with excessive bleeding, and you check that day INR, and suddenly his INR is gone up. So all this we have seen, and we are actually going through a lot of permutations and combinations, especially in warfarin. So we check with different labs, we give the same blood sample in 2-3 labs, and do all these things to get over these differences in different labs or laboratory tests. And every time you are, when the INR is not reached to the desired level, you're actually putting the patient on risk because we don't know the patient can come back with the same thrombotic events. Or if you give her at a higher dose, then there's a risk of bleeding, and the patient can come with a bleeding transformation at a later point of time. So all these risks are there with warfarin. So how about the non-vitamin K oral anticoagulants, called as NOAC or direct oral anticoagulants? These are rapid working. Once it is stopped, it immediately stops over 1 day. So it has much less drug-to-drug interaction. Hemorrhage is much less compared to warfarin. Efficacy on the other side is almost same as that of warfarin. Many studies have shown, so that the evidences we'll see in the next few slides. And continuous monitoring is not necessary as much as warfarin. So when you compare the NOACs with warfarin, there is 19% reduction in the composite stroke or systemic embolic events. If you look at the various studies here, the evidences have shown that there is a favoring towards the NOACs. So there is a greatest advantage. it's not only the reduction in the stroke and systemic embolic events, but also there is significant reduction in the hemorrhagic stroke and all-cause mortality with the Novavax compared to the warfarin. So, except for the GI bleeding, almost all the there is definitely an improvement in the hemorrhagic strokes. The ischemic stroke or hemorrhagic stroke, myocardial infarction, all-cause mortality shows an improvement in the Novavax the group compared to warfarin. Again, this is other few studies again showing that there is a 14% reduction in the major bleed compared to the warfarins. So when we compare this the Novavax, as I said, dabigatran is a thrombin inhibitor. That is a factor 2 inhibitor, whereas rivaroxaban, apixaban, and edoxaban is a factor 10A inhibitor. We know if you look at the coagulation cascade, factor 10A comes much more higher up in the cascade, whereas thrombin inhibitor comes much more lower. So the advantage being that when you inhibit the factor 10A, which is much more higher in the cascade, the efficacy is much better compared to on inhibiting the thrombin. So definitely the rivaroxaban, apixaban has a definite advantage over the dabigatran. If you look at the excretions, the liver metabolism is there with apixaban and rivaroxaban. But if you look at the renal excretion, the least is 25% with apixaban, whereas dabigatran has 80% excretion, renal excretion. So when it comes to reduced renal, reduced creatinine clearance, the apixaban can be used safely until the creatinine clearance comes down to less than 30. Whereas the dabigatran, you cannot use it in renal failure, or even if you use it, you need to reduce the dosage quite significantly. Otherwise, the patient may end up in the bleeding transformation. So there is significantly lower risk of bleeding compared to, if you look at the apixaban, it is much lesser compared to the dabigatran or edoxaban or rivaroxaban. This I am telling again from the different evidences what we will be seeing in the next few slides. So there is an antidote for each of them. So again, as I am talking the clinical profile of Novavax, as I said, the third column is that of apixaban. If you see here, there is no effect of peak concentration, and in the renal impairment, there is no effect. Whereas if you look at the dabigatran, there is you need to be very careful when you're using dabigatran in the renal impaired. There could be 6 times higher concentration of the drug and can lead to the bleeding transformation with dabigatran in the renal failure patient. So how would you use each of this Novavax? See, the dabigatran 150 milligrams twice a day, rivaroxaban 20 milligrams once daily, followed by 10 milligrams. In DVT, we use 15 milligrams twice daily with food for 21 days, followed by 20 milligrams once daily with food. In apixaban, 5 milligrams is used twice a day. So twice a day has been found to be useful. It has much more the linear concentration when it was used twice a day instead of once a day dosage. So apixaban is best used twice a day, 5 milligrams in any non-valvular atrial fibrillations. For venous thromboembolism, 2.5 milligrams twice a day, beginning 12 to 24 hours post-operation. And for confirmed DVT or pulmonary embolism, 10 milligrams twice daily for 7 days, followed by 5 milligrams twice daily. So apixaban can also be used in heparin-induced thrombocytopenia, 10 milligrams twice a day for 7 days, followed by 5 milligrams twice a day. Okay, this I will take just 1 minute here because it's a very important slide. Again, comparing between the different Novavax. This is a phase 3 clinical trial for the treatment of acute venous thromboembolism. If you look, the Apixaban on the last column, the efficacy is better or at least non-inferior, and if the p-value is also quite significant when it was compared with say warfarin. If you look at the different numbers here, the primary efficacy outcome, the Novax versus comparator, dabigatran was 2.4 versus 2.1, whereas here on the Apixaban it is 2.3 versus 2.7, and the incidence study has shown 2.1 versus 1.8. Definitely, the Apixaban has shown a better efficacy compared to the comparator. And even if you look at the bleeding episodes, 0.6 versus 1.8, the bleeding episodes with Apixaban was much less, and it was statistically significant. And there was no the major bleeding, the relevant bleeding also, if you look at it, was 4.3 versus 9.7, again statistically significant. So Apixaban was definitely scored better compared to even rivaroxaban or dabigatran. Again, a meta-analysis showing that very important studies here: Amplify study, Instance study, and the Recover trials. So all this, if you look at the Apixaban comparing to the warfarin, the major bleeding episodes definitely favored the Apixaban compared to the warfarin. So here the x-axis shows the major bleeding, the y-axis shows that of the recurrence rate of venous thromboembolism. If you look at the Amplify study for the Apixaban, if you see, the bleeding was least with the least recurrence episode, whereas other studies had much more higher incidences of bleed and recurrent levels. The Apixaban had the least chances of bleeding and least chances of venous thromboembolism recurrence. That was in the acute venous thromboembolism. And if you look at extended venous thromboembolism treatment also, at the much more later stages also, the Apixaban scored better compared to other the Novax. So if you look at the lower part of the slide, Apixaban has the least the major bleeding compared to the dabigatran and rivaroxaban. And if you look at the efficacy, and even it was better than even the rivaroxaban, and it was comparable to it was comparable to rivaroxaban, and it was better than dabigatran. So there is a lot of studies head-on comparison between Apixaban and rivaroxaban, basically because rivaroxaban is found to be as efficacious, and many studies have shown that Apixaban is actually comparable to rivaroxaban in terms of efficacy, with much less major bleeding and CRNM bleeding. CRNM bleeding is those bleedings which are clinically relevant, requiring hospitalization for the individual. So it's not very minor bleeding that you can just send the individual home, but those bleedings which are not very major bleedings where it is life-threatening, but definitely requires an admission in the hospital requiring monitoring. So those are called CRNM bleeding. So both the major bleeding and CRNM bleeding, you can see Apixaban scored better compared to the rivaroxaban in the various trials. So this was again a meta-analysis, what I'm showing. And if you look at the recurrent outcomes, the recurrence, as I said, there is a high chances of recurrence of VTE in those individuals who already got a DVT or pulmonary embolism. Even in those patients, if you look at compare between the Apixaban and rivaroxaban, Apixaban has much less recurrence compared to the rivaroxaban. So the preferred initial anticoagulant for all venous thromboembolism, with the evidences what we have seen until now, we have moved from the conventional vitamin K antagonist, that is warfarin, From there to low molecular heparin in 2008. From there, we have moved to Novax in 2014. And now we are moved to a time where Apixaban can be used even as the start of therapy, as a de novo, as a treatment for venous thromboembolism. And you don't have to initiate them with either unfractionated or low molecular heparin. So we can directly start them on Apixaban. So that is the greatest advantage. So with all these evidences, what does the guidelines tell us? So the guidelines, you can see the 2000 guidelines was telling us that you can use the Novax in DVT and pulmonary embolism. And it was a grade 2B recommendation at that point of time. But as it has changed from 2016 to 2020, if you see, now it has become with a moderate certainty. So it has become much more higher grade of evidence. Now they are recommending to start directly with Novax over the warfarin. So definitely now the recommendation clearly tells us that you can directly start with the Novax instead of warfarin. So with all the studies, what we have seen, I think we are quite convinced that Apixaban, we are convinced that definitely Novax are better than warfarin for the various advantages what the Novax have. And among the Novax, the Apixaban slightly scores better due to various reasons. So we'll just consolidate whatever we have learned till now. Apixaban has a significantly lower risk of major or CRNM bleeding compared to the different other Novax, and it has lower risk of major GI bleeding. Rivaroxaban, we know it again has a significant higher bleeding compared to the dabigatran or Redoxaban. So anyway, that is not important for us. And Apixaban and Rivaroxaban, if you see, the recurrent events are much lesser with Apixaban, and major bleeding events are also lesser with Apixaban compared to the Rivaroxaban. And even if you compare to the low molecular heparin, enoxaparin, oral Apixaban was associated with clinically relevant reduction of 69% in the major bleeding, and fixed dose regimen of oral Apixaban alone was as effective as conventional treatment consisting of enoxaparin followed by warfarin. So that is what I have been emphasizing on. So you can right away de novo start with oral anticoagulants like Apixaban instead of starting low molecular heparin first and then overlap with warfarin later. So this is the take home message for today. Okay, so as I was talking about why this Apixaban has greater efficacy, probably because it has greater level of factor 10A inhibition. So that is how it is. Apixaban has a greater efficacy and less bleeding tendencies. I think this is all we have discussed. I will not go into the same. So Apixaban adverse events, less than 1%, there is hypersensitivity reaction. It could be the syncope. Post-marketing, we have seen certain cases of thrombocytopenia, hypotension, epistaxis, GI hemorrhage. This is all expected. Abnormal LFT, hematuria, and wound secretion at the incision site. Again, these are all expected. So what are the black box warnings for Apixaban? Discontinuing in patients with non-valvular atrial fibrillation, it can increase the risk of thrombotic events. So when you're stopping the Apixaban, please be careful or consider any other oral anticoagulant before you stop it. And there is increased rate of stroke when there is discontinuation. If anticoagulation with Apixaban must be discontinued, coverage with other anticoagulants should be strongly considered. Again, these are all black box warnings where in the spinal and epidural anesthesia, you can expect some amount of bleeding there. So the epidural catheters, when you are putting, there could be increased the bleeding risk, especially when the patient is already on other NSAIDs or platelet aggregation inhibitors. Or when there is a trauma in the patient, there could be a increased bleeding risk. So Monitor patients for signs and symptoms of neurological impairment when the patient is on Apixaban. Look for any bleeding tendencies. So that as any other oral anticoagulant, we need to look at all the bleeding tendencies. Though it has lesser risk, still doesn't mean that we can give it without warning. There are definitely warning signs. We need to look at the bleeding episodes. But definitely the potential benefit and the risk, what we need to see, and if the benefits are better, much more, so the bleeding risks are quite less, and we need to advise whenever necessary. So use of Apixaban in real life is associated with an overall similar effectiveness in reducing stroke and any thromboembolic events when compared with warfarin. A better safety profile was found with Apixaban compared with warfarin, dabigatran, and rivaroxaban. So thank you. I think I will end up here. Thank you.
Thank you, sir, for this very extensive, lecture on Apixaban. We have came across various aspects, various new aspects which I was not knowing in the clinical, clinical settings. Thank you, sir, for this. With this, I would like to welcome Dr. Subramanyam to the stage and to take the stage and to share with some of the clinical clinical highlights of Apixaban and the case studies which he has experienced with Apixaban. Over to you, sir.
Good evening, the great Dr. Shridhar was very good in highlighting the Apixaban efficacy. And thank you so much, Dr. Shridhar, for extensive presentation. And it was very nice to see. And coming to the anticoagulants, so as an orthopedic surgeon, so my experience is 18 years, and I'm basically a joint replacement surgeon, so I'm trauma surgeon. So I'm seeing a lot of patients sometimes in between with DVT. So mine is more of a prophylactic treatment because of that. So I'll tell my experiences about the cases which I encountered in my practice. So previously, I used to start with ecosprin for all the patients after the lower limb surgery for 2 to 3 weeks initially. But what I faced in my practice was one patient, even after ecosprin, one day suddenly after 2 weeks came to the casualty as a broad-dead patient. So then it really turned me up where I was literally wrong, because this is a long time back. So then I was considering about other anticoagulants. Then came to the dabigatran. So one by one, I'll explain my experiences. So 2-3 years back, one patient after the joint replacement, 3 weeks later, he came with huge hematoma in the knee. So the patient told it is not because of trauma, but I considered all the aspects of the things where bleeding could have occurred. So probably because of dabigatran or trauma, I don't know. But anyhow, I opened the joint and hematoma was evacuated. Then I was literally searching for novel oral anticoagulant drugs like rivaroxaban and Apixaban. Then I actually used rivaroxaban extensively, and later I switched to Apixaban because of the safety profile. So one patient after dabigatran also. So after 3 months, I had put him for 1 month therapy, but after 3 months he came with severe cough muscle swelling with tenderness. So immediately I came to know that this is DVT, and I scanned him, and it was positively DVT. So we had to take him to the vascular surgeon. So after that, later Apixaban I started using extensively. Nowadays, I tell my registrars to as a standing instruction. So first, when the patient is in the ward, I use subcutaneous enoxaparin and for 3 days. Then I'll switch to oral anticoagulant therapy. Nowadays, since the Megatron causes little bit of bleeding episode, so I have switched to Apixaban, and I have not encountered any bleeding episodes with Apixaban. So my practical take-home message for any orthopedic surgeon is so initially when the patient is in the ward, they can use enoxaparin subcutaneously 40 to 60 international units OD. Then switch to oral anticoagulant therapy for all the lower limb surgery, irrespective of the comorbidity. If the comorbidity is there, use it little more strengthened one. Otherwise, I use 2.5 to 5 mg BD for 3 to 4 weeks. Then later, depending on the patient's comorbidity, then I'll continue. So these are the practical aspects which I'm encountering in my practice. So actually, Dr. Shridhar has extensively spoken about the theoretical aspects now. So that's why I thought about bringing up the practical aspects. So if anything is, any doubt is there, please let me know.
Yeah, that's what I was about to tell. Dr. Shridhar has extensively covered Apixaban, and now Dr. Subramanyam has also shared some of the case studies. Thank you for that, Dr. Subramanyam. Now with this, I would like to take some of the questions from the audiences, but I don't think there would be much of the questions as much of that has already been covered by Dr. Shridhar and Dr. Subramanyam. Doctors, from my perspective, what I see this as a therapy is that this is a proper anticoagulant. But if you see it as an orthopedic after an orthopedic surgery or as a prophylactic treatment, what do you think about its role along with an antiplatelet as a dual therapy or as a single therapy apart from what you say antiplatelet? How do you see this as a role?
No, I use only anticoagulant. I don't use ecosprin or
Okay.
antiplatelet. Previously, I used to use that, but I don't find anything much different because Apixaban is more has more efficacy. So the pathway is different, the effect is different. So I find it Apixaban is enough to take care of the DVT prophylaxis.
Okay. Yeah, Dr. Shridhar.
Yeah, I think Iqbal, what the problem is, I think antiplatelet and anticoagulants are a two different class. Each of them have their own places. I think as Dr. Balasubramanyam rightly said, here there is no role for antiplatelets at all. So it's antiplatelets have to be used in those places where we are, say, for the coronary artery disease, where we are suspecting or as a preventive aspect for those patients who are having increased thrombotic events. So this is what we are here. Anticoagulation using is as a secondary prevention of clot formation. So here there is a definite role for only anticoagulants and not antiplatelets. So antiplatelets doesn't help in this scenario at all. Even I do see such prescription sometimes, but that a lot of places where anticoagulants has to be used due to risk of bleeding. Some of them use antiplatelets, but I think that is completely a wrong the prescription, and that is why this talk. I think this type of talk has to be. I think thanks to Pulse because I think this topic is very important one. As I said in the initial slides. We talk so much about MI, we talk so much about strokes, but we hardly talk about the venous thromboembolic. So I think the importance of the oral anticoagulant, especially with see, we were always scared because of that warfarin, which was used to cause bleeding. But now we have this newer agents. The bleeding episodes, I treat a lot of thrombotic venous thromboembolic patients, and I don't see the same bleeding episodes what we used to see in the earlier the context. So definitely the NOACs have changed the way we treat venous thromboembolism, and wherever it is indicated, it has to be used. To consolidate what Dr. Balasubramanyam said, I had one patient very recently who was having atrial fibrillation, who was on oral anticoagulant. As I put in my own slides, stopping oral anticoagulant, you need to supplement them with other anticoagulants. Say, for example, when you're planning a surgery for an individual, if the patient is on oral anticoagulant, stop that oral anticoagulant and supplement them with, say, unfractionated heparin, because that is a short-acting one. So you can just stop 6 hours prior to the surgery, heparin, and you can perform the surgery, and within 24 hours, you can restart the oral anticoagulants. So that is what we need to do. But for one patient recently I had, because this patient again was for a major surgery, we had actually stopped the oral anticoagulant 2 days prior. So that is for any major surgery, we need to stop the oral anticoagulant at least 2 days prior, or 2 or 3 days prior, depending upon the surgery. That is the recommendation. We had stopped it to 2 days prior, and we gave low molecular heparin on the day 1. On the second day, we didn't give it because it was low molecular heparin, because the patient had serious higher risk of bleeding, because the patient was quite elderly, 85-year-old. But immediately post-op, patient developed the major stroke, where the patient we couldn't survive. The patient did not make it up. So as I said, even 12 hours, 24 hours of stopping of drug can sometimes be detrimental. So I mean, just to highlight the importance of oral anticoagulant, this and another patient we had, pregnant patient. This again, thrombotic events are increasing these days. I don't know, for some reason. In the last 2 years, at least, we are seeing young people coming with thrombotic events, and the cortical vein thrombosis again is increasing like anything, especially in a pregnant ladies who doesn't have any other predisposing factors. They are coming with high pregnant or postpartum patient, the individual coming with headache. You should always look for the venous thrombus, cortical venous thrombus. Very high incidences these days. For some reason, in the last 2 years, people point to coronavirus, vaccines, or whatever. So whatever the reason it could be, but definitely the thromboembolic phenomenon has definitely increased. I would say, I think everybody here, all the delegates here would agree on this. And the more so now that this topic is become more important now, because we have to, whomever we think are at a high risk of developing venous thromboembolism, who has risk factors. So, for example, patient is obese, patient is having is an obese smoker who is having hemoglobin is more than 16 or 17, hyperviscosity. So the patient is coming with DVT, leg swelling, even after a small driving for a short trip. So all these patients are at a high risk, and those we should consider to put them on secondary prevention. I think that is very, very important.
Yeah. So this was quite an insightful, sir, regarding antiplatelet, because I have seen many orthopedics using antiplatelets as an anticoagulant pre-surgery, as as a prophylactic treatment, and also post-surgery for 10 to 14 days, normal period. So to come on to this topic, what should be the ideal duration of the initiation of the therapy post surgery of TKR or THR in case of Apixaban? What do you recommend?
Yeah, after the surgery, once the patient is in the ward, we start with Emboxan. That is what I do, my protocol. So 40 or 60, depending on the patient's comorbidity. And once the patient gets discharged, so along with the discharge medicine, I start with Apixaban for 2.5 BD, 2.5 mg BD or 5 mg BD depending on the comorbidity, at least for 4 to 6 weeks minimum, especially TKR and THR. Actually, I have stopped ecosprin more than 5-6 years now, and I don't use ecosprin. I use only Apixaban. Previously, I used to use dabigatran. Then came to Xarelto, that is Rituximab. Then now, since last 2 years, I'm using Apixaban for all the patients. And even any lower limb surgery, fractures. So naturally, patients will be immobile, so they can't move around. Even though they move around, they don't do the exercises. So I make sure that all the patients are put on anticoagulants. Some patients are healthy. Okay, I put on minimum dose, 2.5 mg OD also.
Okay. Yes, Shridhar sir.
Yeah, see
What are your takes on this?
Yeah, the recommendation is any surgeries post-operatively, you need to start oral anticoagulants 24 hours later. If it is a very major surgery, then you can start 48 hours post-surgery. And as Dr. Balasubramanyam said, when to stop the oral anticoagulant, that is a question mark. So that depends upon the patient's predisposing factors. Say, for example, patient has many other risk factors, as I said, smoking, obesity, the prothrombotic events in the past. So all these individuals need to take it for a longer time, say sometimes even 3 months. If necessary, we may have to continue it for 6 months. If you are suspecting the patient may have recurrence of the thrombotic events, then probably you may have to even give it for lifelong. That is for a very few subset of patients, but most of them will stop it at say 2 weeks or 3 weeks. If the patient doesn't have any other risk factors, I think once the patient mobilizes very well, you can stop oral anticoagulant. But if you look at specifically orthopedic surgeries where the patient is immobile for a longer period of time, I think the 3 weeks is ideal time. For most of the, I think Dr. Balasubramanyam would give us more light on that. I think most of the surgeries, I think by 3 weeks, I think they should be able to mobile themselves. So I think 3 weeks is the ideal time. And if you feel the patient has other risk factors, please continue for at least 3 months. So that is what the recommendation tells us. And if you feel the patient has higher risk factors, definitely continue for 6 months. And if you feel the recurrence is there, then you have to continue beyond 6 months. Recurrence by the sense, for example, patient has already had a thrombotic event in the past. Patient already had a stroke in the past. Patient already had a DVT in the past. So those patients, we may have to consider the continuing of the anticoagulant for sometimes even lifelong, or say any of the antiphospholipid syndromes or protein C, protein S deficiency. Definitely, we need to consider all these patients. We need to continue for lifelong. I have some 4 or 5 patients who are having recurrent strokes. So all these 5 patients of mine are on lifelong oral anticoagulation. And unprovoked unprovoked thrombosis is again an indication to have lifelong anticoagulation. Unprovoked. Say if there is a provocation, for example, say surgery has caused some venous thrombus, it's okay, you can stop it at 6 months. But without any predisposing factor, without unprovoked any thrombotic event, those are the individuals you need to actually consider for lifelong, not those who had a reason for having a thrombotic. If they have a reason, you can stop it. But if they don't have a reason, then you need to continue them for lifelong, because those are the individuals who will have a recurrence of the thrombotic event, because you don't know why it has happened.
True.
So unprovoked thrombotic events need to continue the anticoagulation for lifelong. So that is the take-home message.
Yeah. So just to add on to this, there are few of the articles or the trials have shown the efficacy of Apixaban in fracture healing. Do you have any clinical experience or clinical points to add to this? The role of an anticoagulant in fracture healing. What an anticoagulant can do?
Seriously, I don't know anything about it. I'm not come across like that. No, not about the
Okay.
article. I have not given a thought about it actually.
Sorry, I didn't get the question. Anticoagulation in
Fracture healing.
fracture healing. Okay.
Fracture healing. Fracture healing. Yeah. So yeah. And sir, apart from that, do you think the need of an anticoagulant in the case of hemiarthroplasty?
No, that's what I told you. All the lower limb surgery. So after the surgery, all the lower limb surgery, hemiarthroplasty is also hip surgery. Any hip surgery, knee surgery is high publicity for DVT. No, that is what
Yeah.
I do. All the lower limb surgery, whether it is fracture, whether it is TKR, THR, hemiarthroplasty, nailing. Because I have seen patients after nailing also coming with DVT. So that's what I told my experience. One patient I had put on ecosprin, so he was brought dead after 2 weeks. So that is the eye opener for me actually at that time. So then I stopped ecosprin and started with the oral anticoagulants for all the patients after the lower limb surgery, depending on the patient's comorbidities, type of fractures, their mobility status. I use the doses according to that. But
Okay.
after the Apixaban has come up, so now I'm putting the Apixaban for all the patients blindly without thinking, because I know the serum bleeding is very less, so I can go and sleep peacefully.
Yeah, sir. Thank you, sir, for that. Coming on to some cardiovascular events associated. So, answer this. What do you think should be ideal duration in case of treatment of stroke? The Apixaban duration in case of stroke, the treatment, because ideally it is for 7 days, 10 mg BID. But what is your clinical point to this?
Sorry, you're asking for Apixaban in stroke?
I was asking about Apixaban and what could be the dose regime in case of the treatment for stroke? Because ideally it is around 10 mg BID for 7 days. So what's your take?
See, Apixaban, we do not recommend regularly in all stroke patients. See, up to 12 days, we start usually oral anticoagulants. A lot of studies are there. I think one is a COMPASS study as to when you need to treat an acute stroke with oral anticoagulant. Say, for example, a patient coming with transient ischemic attack, TIA, you need to start oral anticoagulant from day 1. I think that formula, I think 1, 3, 6, and 12. That is what is followed. 1 is for TIA, 3 is for minor stroke, 6 is for moderate stroke, and severe stroke 12. So those are the days we need to start oral anticoagulants. If you are considering the individual has some risk factor. So the risk factor for stroke, if it is say atrial fibrillation, for example, then definitely the patient has to be on oral anticoagulant. Not all stroke patients, not all infarct, the ischemic strokes need to be on oral anticoagulants. Or if the stroke is due to any other predisposing factors, as I was talking about the obesity or smoking or any other diabetes, hypertension. So any of these risk factors patient is having, then definitely it is an indication. But otherwise, not all strokes need oral anticoagulation. In those individuals, definitely antiplatelets is what is recommended as a routine for in all stroke patients, ischemic strokes. And we consider oral anticoagulants only for those strokes which are due to any of the predisposing venous the thromboembolism predisposing factors. Say a patient has hyperhomocystinemia. Yes, for that individual, definitely he has to be on oral anticoagulant. So how to start, when to start? So as I said, we have to follow this 1, 3, 6, 12 formula. Day one, you need to start for TIA. You don't have to wait. 3 for those who have minor strokes. 6 for those who have moderate strokes. 12, you need to wait for 12 days for those who have a major stroke, because those are the individuals when you start oral anticoagulant, they may develop hemorrhagic transformation. So we cannot just start off with oral anticoagulant for major strokes. So we need to wait, make sure that may get a CT scan on the 10th day, make sure that there is no hemorrhagic transformation, and then start with the oral anticoagulant. But if you're talking about the antiplatelet starts from day, not hour 0. Whenever you diagnose stroke, you need to start antiplatelet. So antiplatelet here is a different thing, and anticoagulant we need to start as per this. Now one more study has come where they say 1, 2, 3, 4 formula, where the same, instead of 1, 3, 6, 12, they are saying you can start off much more early for our TIA for day 1, and for minor, moderate and major, you start with 2, 3rd and 4th day. So that is the one more study has come in recently that says you can start off much more earlier. So that is the present recommendation which is there. But not all acute strokes need oral anticoagulant.
Okay. Sir, apart from this, what you say about the safety aspects of Apixaban? What do you think should be done on a regular basis while on Apixaban? A test that should be done, hematological test.
Apixaban, you just need to look at the platelets. So sometimes the platelets can drop. It can cause thrombocytopenia in certain individuals, some individuals. If you are not for everybody, only if at all you're suspecting if the patient has some bruising or has some, if you suspect some bleeding episodes. So those individuals get one complete blood count to look at the platelet count. So some people can come with thrombocytopenia, but otherwise none of the tests will tell you. Even PTINR may not be very helpful in blood tests to consider whether the Apixaban is working or not.
Yeah. Yes, Dr. Subramanyam, your takes on this?
Actually, hematologically, I don't do any test for it actually. So because I don't see any problem with Apixaban. No need to.
Okay.
My practical thing.
Okay. Apart from this, sir, there is no such no major drug-drug interaction. But since Apixaban is majorly metabolized in the liver via the CYP enzyme, and it is one of CYP inducers. So, do you think any drug like amiodarone, in case of cardiovascular, or antibiotics, that can be a substrate for the CYP inhibitors? So, any concomitant medications that should be avoided in this case, or to look out for such drug and drug interaction?
Yeah, I think those which induce cytochrome P450 and Y334,
Yeah.
all these drugs have to be avoided. All the antifungals, anti-cancer medications, certain anti-cancer medications, you have to be very careful when you are using. But most of the drugs we can use safely. When you only have certain anti-cancer drugs and antifungals when you are using, you have to be a bit careful. I think most of the drugs you can use it.
Also, regarding the BMI, the BMI has to be considered while using Apixaban?
In elderly, I don't know about the BMI, but if it is, yeah, definitely yes. Those who are quite obese, I think, not very sure. I think more than 110 kilos or something, I think you need to use a higher dosage. And elderly person more than 60 years, definitely you need to reduce the dosage. Otherwise, I think most of the individuals you can be safely used. And I think these two things. One is increased weight and elderly person, more than 65 years, 70 years, if they're very lean, if the creatinine clearance is less than 30, you have to definitely be careful and reduce the dosage. If the indication is 5 milligrams, reduce it to 2.5 milligrams in such individuals.
Yes, Dr. Subramanyam, your take on this?
I don't give much importance to BMI because all the patients need anticoagulants after TKR and THR. But depending on the patient's obesity status as well as their comorbidities, I play with the dose. So sometimes 2.5 mg OD also, sometimes 5 mg BD also.
Okay.
Depending on that.
Okay. So that's all from my side. I think there are no more questions from the audience.
Dr. Hasnath, I got a question here. There's just one question. This is, of course, for Dr. Shridhar. It is now, as you know, sir. I hope I'm audible, sir.
Yeah. Please tell me. You're audible.
Sir, this is Pompa Ghosh. This question is like nowadays there are so many patients who are taking statins along with aspirin, and in case they go in for a surgery, how safe will be a anticoagulant, and when aspirin should be stopped, when anticoagulant can be started? So that is a question, sir.
Yeah, Pompa Ghosh, I know there is a common thing because most of them will be on ecosprin for whatever condition they have. So ecosprin has to be stopped at least 4 days prior to the surgery. Say if the individual is also on oral anticoagulant for whatever condition the patient is having, say already patient is having some predisposing thrombotic event. Say for example, the person may be having atrial fibrillation along with hyperdyslipidemia and cardiac issue. So that individual may also be on a oral anticoagulant along with ecosprin. So you need to stop ecosprin at least 4 days prior to the surgery, whereas anticoagulant so you can stop just 2 days prior. So the question is, when you want to start, is that the question?
Yes, sir. Because before surgery, as you said, it has to be stopped. Then after the surgery, when to start anticoagulant and when to start aspirin, because he has to take the statins. That
so post surgery, I think starting oral anticoagulant is more important at the point of time. You can ecosprin, you can wait for at least 2 days, but oral anticoagulant you have to start at least 24 hours post surgery. If it is any surgery for that matter. If it is a very major surgery where there is a lot of vessel opening, then you need to wait for 48 hours. So that is the recommendation. Otherwise, most of the surgeries, 24 hours post surgery, you can start off. If you feel the patient is having a very high prothrombotic event, hyperthrombotic risk, then even as I said, prior to 2 days prior, you stop the oral anticoagulant, and as I said, you need to supplement them with say low molecular weight heparin for at least 1 day. Just before the surgery, you can stop it. 6 hours prior to the surgery, you can stop it and then go ahead with the surgery. And post surgery, 24 hours later, you can start off with oral anticoagulant. And later on, you can start off with ecosprin, because ecosprin we can actually start off much more later, at least 2 or 3 days later. So 24 hours later, you need to start off with oral anticoagulant. That is the recommendation.
Thank you, sir. But in this regard, has Apixaban any advantage over the others? Any particular?
Definitely, that is what various studies have shown us. Definitely, the bleeding risk is definitely better. The efficacy, almost all the newer NOACs remains the same. The rivaroxaban is as efficacious as Apixaban. But if you look at the bleeding risk, even if you look at between rivaroxaban and Apixaban scores much better and much less bleeding risk compared to rivaroxaban. So in that way, definitely Apixaban has scores over other NOACs.
Thank you, Dr. Shridhar, for the detailed answer. Thank you so much.
Yeah. Thank you.
Yeah, so Dr. Shridhar, I just got another question for you. So, do you think that Apixaban is very safe in cases of in case of CKD where the GFR is less than 30?
Less than GFR 30, we should be very careful because for them, not much studies are there. So the bleeding risks are high. I think for those individuals, the best would be using heparin, the low molecular heparin. And even those, we need to reduce the dosage. We cannot use the same dosage. Here, if at all, you can start off with 2.5 milligrams. Instead of twice, you can start off with once a day. Then monitor the patient regularly. So monitoring, hematological monitoring, you were asking, Iqbal. See, only thing what we can consider is factor 10. If only few labs do it, you can look at the factor 10 itself. The factor 10 assays are available in certain labs, but I think definitely it's a very costly test and not easily available everywhere.
Yeah.
I think other than that, we cannot, we do not have any other tests to monitor for the Apixaban.
Yeah, sir. So I think that was very elaborative answer. Just to finish off, sir, I would like both of you to just explain. Have you ever came up with anything regarding the toxicity of Apixaban in any of your patients? Starting with you, Dr. Subramanyam.
Pardon me?
The toxicity of Apixaban in any of the patients. Yeah.
No,
Yeah.
not yet. I have not faced anything.
Okay.
For
You're asking about
it has
toxicity?
been a wonderful drug.
Yeah.
For me, it is a wonderful drug. I have not faced anything.
Okay. Great, sir. Great. Over to you, Dr. Shridhar.
Yeah, I think we need much more experience on this molecule. We have been using, but we're not seeing much toxicity right now. But I think this is too early to say anything about it. I think as we start using more and more of Apixaban, I think we'll have much more experience on this. I think one is definitely you need to look at thrombocytopenias. That is one thing for any of the anticoagulant you are using. I think other than bleeding episodes, thrombocytopenia is one thing which you need to be very careful about. I think other than that, nothing much I will do.
Okay, great, sir. Great. Just to end the session, both of you can just take home message for our audience.
Yeah. So as I think all the doctors here, thanks for the patient hearing. So we have been talking about the importance of oral anticoagulant in the different medical conditions in all the prothrombotic events. So patient comes with any of the thrombotic events, just don't send them with antiplatelet. Look for the causative factor because if you are able to treat the cause, then probably the patient may never have another thrombotic event. For example, the patient is a chronic smoker, comes with hemoglobin of say 19, 20, 21, is polycythemia. So that itself may be a predisposing factor for thrombosis. So the patient stops smoking, you do some plasmapheresis for the patient, phlebotomy for the patient, you remove some blood, get the hemoglobin down to say 14 or 15. Patient may become completely normal. So any thrombotic event, just don't send them with putting them on antiplatelet and forget it. Find out the risk factors for the thrombotic event, why it has happened. So you need definitely that may require a lot of blood tests and investigations. But if you convince the patient as to why you are doing it, I think many of them will get it done. And meanwhile, to choose between the antiplatelet and oral anticoagulants, definitely you need to be very careful. And when to start and how much to start and when to stop it. Again, all these things becomes very important. If the patient already has a predisposing factor, if you remove the predisposing factor, then you can stop the oral anticoagulant. But the individual is having unprovoked thrombotic event, then you may have to continue for the anticoagulant for a much more longer time, sometimes even for lifelong. So this will be my take-home message.
Thank you, sir. Thank you. Over to you, Dr. Subramanyam.
Thank you so much, doctors, for the patient hearing. Sir, Dr. Shridhar, talk was excellent. My take-home message is orthopedic practicing orthopedic surgeons don't neglect the problem of DVTs. Always consider it as a serious complication, because I have seen it. So until you see one big complication, you will not understand it. So make sure that you don't end up in that complication. So make sure you start with anticoagulants for all the lower limb surgeries, irrespective of the surgeries. So depending on the patients, depending on the comorbidities, you can alter the dose. But don't forget to start the anticoagulant. That should be your most important discharge summary medicine. So make sure that you check it with your registrar whether they have put it or not. And ecosprin, only ecosprin is not enough. So many patients might face problems later also. So basically this is a prophylactic. What is prophylaxis means? Don't end up in complication. So instead of treating the complication later, don't end up in complication. This is my take home message.
So thank you. With this, I would like to thank the Sir Dr. Shridhar and Dr. Subramanyam for this wonderful, wonderful event, and a lot of insights on Apixaban and its clinical use, and how we can rationalize the use of this molecule in the clinical practice. So thank you, thank you, doctors, for the wonderful event and the wonderful time for this event. Thank you from all
Thank you
behalf
so
of the
much.
Pulse Pharmaceuticals. Yeah, thank you,
Thank
audience.
you.
You have been a great
Thank you,
audience.
Pulse.
Yeah,
Thank you.
thank you, sir. Yeah, bye.
Thank you. Bye.
Thank you, sir. Thank you, Dr. Balasubramanyam. I guess Dr. Shridhar sir is not here. Maharishi, you can stop the recording and the live session.
Okay, ma'am. Okay.